We have another great issue this month, beginning with a trial from Diabetes Care called the TIGHT study, which is the results of a randomized trial of intensive glucose management using CGM versus usual care in hospitalized adults with type 2 diabetes. We are having the first author discuss this trial, and the results of the trial are not what anyone expected. Next, we're going to talk about an article published in the New England Journal titled Tirzepatide for Obesity Treatment and Diabetes Prevention. Then we're going to discuss an important article also published in the New England Journal on intensive blood pressure control in patients with type 2 diabetes. And these are results that also may or may not surprise you, but add a lot to our field. Then, the association of insulin resistance with radiographic lung abnormalities and incident lung disease, not an area that we usually think of as associated with insulin resistance. Then, association of life course associations between ambient fine particulate matter and the prevalence of prediabetes and diabetes. We're seeing a little bit of a theme here. The lungs, and the rest of our body all are affected by similar things. In one case, insulin resistance. Here we're going to see about air pollution. And finally, semaglutide in persons with obesity and knee osteoarthritis, published in the New England Journal, talking to one of the authors. For our first article this month, we will discuss an article from Diabetes Care titled Results from a Randomized Trial of Intensive Glucose Management Using CGM versus Usual Care in Hospitalized Patients with Type 2 Diabetes, the TIGHT study. Joining us to discuss this article is the first author of the article, Earl Hirsch. Dr. Hirsch is a professor and the Diabetes Treatment and Teaching Chair at the University of Washington School of Medicine in Seattle, Washington. Earl, welcome.
Thank you very much for inviting me. This is an important study.
It is, Earl. And when I saw this, I thought, wow. And I expected an outcome that was different than what we saw, and we'll talk about that. Can you first give us some background for understanding the article, putting it into context, and why you all undertook it?
Yeah, thank you for giving me the opportunity. CGM is becoming standard of care in the United States in particular, especially for people who are already using insulin. We got our first taste of routine use of CGM in the hospital during the COVID pandemic, of course. But as the technology is becoming more common, and now here late in 2024, we have over-the-counter CGM, we wanted to do a trial looking at what happens when we use CGM versus standard of care in hospitalized patients. We decided, Neil, to do this in academic medical centers who already had glycemic control teams. So the University of Washington, for example, we have a team that, yes, we make protocols for everybody else, the house staff, the hospitalists, and so forth. But these are teams that go around and see particularly the more difficult patients. We have endocrinologists, nurse practitioners, endocrine fellows, and so forth. We wanted to make this a pragmatic trial from the point of view that we didn't use research nurses. We used the nurses that were already there. It would have been too difficult and expensive. And we had each of the 6 academic centers use their own protocols. We did not standardize the protocols. Again, in retrospect, we went back and looked at all of these decisions we made, but the hypothesis was we would be able to have better glucose control looking at mean glucose in those individuals that were using CGM, and the nurses saw it, the doctors saw it, everybody saw it, compared to the standard of care group that were using blinded CGM. Okay, so we have one group with CGM that everybody could see, and by the way, the physicians and the house staff and the fellows and the nurse practitioners, they could see the CGM on their phone. And then there was blinded CGM. We decided to look at the most common type of patient, non-ICU patients, type 2 diabetes already. We looked at people who came in with already, for the most part, already on insulin therapy. And as it turns out, these patients came in and we had 110 patients enrolled in the study. They had a very wide range of hemoglobin A1C, and this turns out to be important. The A1C ranged from 5.5 to 15.4%, but more importantly, the mean A1C was 8.9%. And as it turns out, that's not really that different than general hospitalized patients coming in, whether it's an academic medical center, a community medical center. People coming into the hospital, as a rule of thumb, don't have the best glucose control. So that part was, I think, very usual, although it may have impacted the results too. And like I said, we use 6 medical centers around the United States. And the results, of course, at the end of the trial, where we had about half with the intensive therapy, half with standard care, when we just looked at the point of care glucose before starting, it was interesting because the glucose was 186 with the intensive therapy and 175 with the standard therapy. But what happened at the end when we looked at the primary endpoint, there actually was no difference. Now, the target was a glucose of 90 to 130 in the intensive therapy group versus the usual standard of care in the hospitalized patients of 140 to 180. But as it turns out, even though the target was 90 to 130, the intensive group had an average glucose of 170 and the standard group was 175. Now, that was not statistically different. Numerically, the glucose was a little bit lower in the intensive group, but very few people. Only 7% of the people in the intensive therapy group were able to get the glucose levels down to 90 to 130, and that compared to 6% in the standard group, which was not the issue at all. And when we went back and we dove deep into the glucose levels, what we found was really interesting. We stratified it by hemoglobin A1C. And if we look at those with A1Cs less than 7.5, we found that the glucose levels were 155 with intensive therapy versus 170 with standard. So 155 to 170, not even close to the 9130. A1Cs between 7.5 and 8.9, we saw this delta again, where the glucose levels were better with the intensive therapy, 166 to 182. So at least for A1Cs under 8.9, they were better, but they weren't even close to the target. But what was the most interesting were A1Cs above 9%. Because above 9%, once again, we see this higher glucose level with intensive therapy. It was 155 with less than 7.5, 166 with 7.5 to 8.9, and 188 if the A1C was above 9%. But in those people with standard therapy, and we think this was a statistical fluke, the glucose levels were actually numerically lower in the standard therapy group. It was 188 with intensive therapy. Standard therapy was 174. And we don't understand why, but the bottom line is, overall, the CGM did not make any difference. In those individuals with A1Cs less than 9%, it was 161 with intensive therapy, 175 with standard therapy. And so the people who came in with better glucose control, it was numerically better. And I should also say hypoglycemia was very low. There was no differences in hypoglycemia in these academic medical centers. And so the bottom line is, why did we see these results? And we used the hospital nurses, we used everyone using their same protocol. And in retrospect, should we have standardized the protocol? Should we have used one of the computerized hospitalized algorithms that are on the market that more and more hospitals use, although not as much in the academic hospitals? But if I had to put my finger on the number one reason why we saw what we did, and we're still looking at this data, literally this week we're looking at this, it has to do with the timing of the insulin in the hospital. Now, we know if somebody has to go to a radiology procedure, if somebody has to go to occupational therapy and they ate and the insulin didn't come yet, the insulin is given very late. But what I didn't appreciate is that many of the hospitals, the nursing culture has changed to the point that the insulin is intentionally given after eating. Sometimes it's in the protocol, which we learned. Sometimes it's just the nursing culture. And when you give the insulin after one eats and you're doing point of care glucose testing, the glucose levels don't look horrible. But if you do that with CGM, you see these big spikes, in particular, Neil, in particular in those people with A1Cs over 9% who are the most insulin deficient. And we were shocked at this because we did not know this. And I personally did not appreciate how the culture in the hospital, even at my own institution in the last 5 years, and I think part of this has to do with COVID, the fact that insulin given after one eats, which is such a big deal in our clinics and our outpatient side, especially with our type 1 patients. As it turns out, it's the same in our type 2 patients, especially in the hospital. And this, in my view, was by far the number one reason why we saw what we did. And of course, if I was going to do this study over again, I would have made this point a much bigger part of the trial. And the bottom line, whenever you do a trial like this, even though you look at the data and you say what was a negative trial, philosophically, I learned so much from this trial. I don't look at it as a negative trial at all. I think we need to work with our nursing staffs and the protocols about the timing of insulin. It has not been as big of an issue as maybe it should have been. You may know I trained at Washington University in St. Louis in the late 1980s. And one of my mentors, Dr. Julio Santiago, who was in charge of pediatric endocrinology at St. Louis Children's Hospital, this was the number one thing he taught the residents, the fellows, the parents. And I'm going back to the 1980s right now, thinking of Dr. Santiago as I look at these data. I want to say my final comment when I look at this is that we know CGM is going to become not less, but more prevalent in the hospital. And this is because of the penetration of CGM in insulin using patients, both type 1 and type 2. Now we have over-the-counter CGM. We, at some point in 2025, there, from what I am being told, there actually may be an FDA labeling for CGM in the hospital. And this study is important because it's giving us a heads up as more and more people start using CGM in the hospital for this population. And then not to mention, of course, the people who already come in, not only using CGM, but using CGM with automated insulin delivery, which in our hospital, we certainly don't stop the CGM for that. So that's a lot of information, but it was, I think, a really important illustrative study that we learned a lot from.
Earl, I love your analysis, and I particularly enjoy the way you really point out that even when things don't go the way we plan, the results seemed like they'd be obvious ahead of time. They were the opposite of what we would have anticipated. There were still important things to learn, and thanks so much for pointing them out for us. Dr. Earl Hirsch, thank you so much for joining us.
Thank you again for having me.
Our next article is from the New England Journal, and it looked at tirzepatide for obesity treatment and diabetes prevention. So this was a phase 3 double-blind randomized control trial in which over 2,500 participants with obesity, of whom 1,032 also had prediabetes, were assigned in a 1-to-1 ratio to receive tirzepatide at a once-weekly dose of 5 milligrams, 10 milligrams, or 15 milligrams, or placebo. Analysis involved the participants with both obesity and prediabetes who received their assigned dose of tirzepatide or placebo for a total of 176 weeks. That was followed by a 17-week off-treatment period. The three key secondary endpoints, which were controlled for type 1 error, were the percent change in body weight from baseline to week 176, the onset of type 2 diabetes during the 176-week and 193-week period. At 176 weeks, the mean percentage body change in body weight among the participants who received tirzepatide was a decrease in 12.3% with the 5 milligram dose, a decrease in 18.7% with the 10 milligram dose, a decrease of 19.7% with the 15 milligram dose, and the placebo had a decrease in 1.3%. Fewer participants received a diagnosis of type 2 diabetes in the tirzepatide groups than in the placebo group, 1.3% versus 13.3%. After 17 weeks off treatment or placebo, 2.4% of the participants who received tirzepatide and 13% who received placebo had type 2 diabetes. Other than the COVID pandemic, which had nothing to do with this, but happened contemporaneously, the most common adverse events were GI, most of which were mild to moderate in severity and occurred primarily during the dose escalation period in the first 20 weeks of the trial. There were no new safety signals identified. Neil?
John, we've spent the last 10 years of our lives every month getting on this podcast, talking about the consequences of diabetes and how to avoid those consequences, how to treat diabetes. It is pretty amazing now to see a medicine that in people with prediabetes, with obesity and prediabetes, can decrease progression to diabetes over 176 weeks by 93% compared to placebo. And of course, treating obesity at the same time. I don't think when we started these podcasts that we ever could have imagined seeing this kind of result. And what's also amazing is not only do we see slowing of progression of people or decreasing it by over 90%, but we see reversion for over 90% of the people treated with tirzepatide, reversion of prediabetes to normal glycemia over that period of time. And if we look at the 15 milligram dose group, that was over 93% of people reverted to normal glycemia, and that compares to 58% in the people who received placebo. The number needed to treat to prevent one case of diabetes was 9. The other thing about this trial is this was a long trial. This was 3 years long. And so it speaks to the durability of effect. And finally, they looked at quality of life parameters, and people rated their quality of life in the group on tirzepatide as better, improved physical function day to day as better than in the placebo group. So I think this is important. This adds to the wealth of data that we now have on GLP-1 treatment and dual GIP, GLP-1 receptor agonist treatment for both the treatment of diabetes, the treatment of obesity, and the ability to address prediabetes, which even separate from its effect on progressing to diabetes, increases cardiovascular risk. The ability of this class of medicines to address all of those issues. Our next article, a critically important article, is from the New England Journal of Medicine titled Intensive Blood Pressure Control in Patients with Type 2 Diabetes. The authors here studied an important question. Does treating systolic blood pressure to a level less than 120 yield a better outcome than when patients are treated to a systolic less than 140? They enrolled patients 50 years of age or older with type 2 diabetes, elevated blood pressure, and increased risk of cardiovascular disease at 145 clinical sites across China. Patients were randomly assigned to receive intensive treatment that targeted a systolic blood pressure of less than 120 millimeters of mercury versus standard treatment with a target less than 140 for up to 5 years. The primary outcome measure was a composite outcome of non-fatal stroke, non-fatal MI, treatment or hospitalization for heart failure or death from cardiovascular causes. Over 12,800 patients were randomized, and 45% were women. Mean age was 64 years of age, plus or minus 7.5 years. At 1 year of follow-up, the mean systolic blood pressure was 121, and in the intensive treatment group, and 133 in the standard treatment group. There was a mean follow-up of 4.2 years, and the primary outcome event in the intensive treatment group versus the standard treatment group, the primary outcome had a hazard ratio of 0.79, or to say it a different way, a 21% decrease in the primary outcome in the intensive treatment group, and that had a p-value of less than 0.001. The incidence of serious adverse events were similar in both treatment groups, though symptomatic hypotension and hyperkalemia occurred more frequently in the intensive treatment group. John?
I think this is something that we've talked about a whole lot, and I think we talk about clinically. The Accord trial came out in 2008 and really didn't show a huge difference between the two groups. And it was 140/90 truth. But then as you have moved on, we've seen the diabetes groups that talk about treatment guidelines, the ADA talking about that 130/80, without really all this big study that really had kind of 130/80 as that compromise. The Sprint trial came out really looking at that 120/80 as that kind of perfect level to really have people's blood pressure below. This study isn't completely surprising. And when you dive into it a little bit, one, it was all done in China, so a homogeneous population that may or may not translate exactly to people in the United States. 60% of people in both groups were on statins. And yes, we don't have all our patients with diabetes on a statin, but every adult patient, over the age of 40 should be on a statin. So I don't know if you lose a little bit of that. Some of the surprising things, and I think if you and I were critiquing the Sprint trial, I think one of the things that we would bring up is sometimes in lowering people's blood pressure, especially older people, you start getting into problems with hypotension. You start getting problems that might be specific to one of the agents that we might have people on a different blood pressure agent. You're more likely to have electrolyte abnormalities with the thiazide diuretics. You're more likely to have cough with the ACE, angioedema with the ACE, bradycardia with beta blockers, et cetera. And really, in this study, there was really very little, nothing that was statistically significant difference between the two groups with regard to any of the side effects that one might expect with regard to lowering people's blood pressure more. That doesn't completely jibe with what you and I would suspect, because certainly we have seen patients. The study didn't have a whole lot of people over the age of 80. So I think taking this paper and extrapolating it out to include our very old patients, I think is a bit of a leap of faith. But there's probably more and more evidence that 120/80 is better than 130. And certainly if we can achieve that without a whole lot of flesh equity, if patients are not having a problem with it this way or that way. I think one of the things also is if we use a combination pill, if we use combination inhalers, patients think they're on one inhaler. If we use a combination blood pressure pill, patients think they're on one pill. And I think that's one of the things, because patients really, boy, I'm taking 14 pills, doc. Can you decrease it? Sometimes if you can combine things, if that can work out for you, certainly you can decrease the burden of pills. And I think that probably would increase adherence, which is probably step number one for controlling hypertension. Our next paper is from Diabetes Care, and it looked at the association of insulin resistance with radiographic lung abnormalities and incident lung disease, the Framingham Offspring Study. This study was looking at insulin resistance as a risk for lung disease, but overall, historically, objective evidence has been limited. Participants without baseline lung disease underwent repeated measurements of fasting insulin and glucose levels over an average period of 13.6 years, from which a time-weighted average homeostatic model assessment of insulin resistant, or HOMA-IR, was calculated. Each participant then underwent a cardiac-gated whole lung computed tomography scan, CT scan, which was analyzed for the presence of emphysema, interstitial lung abnormalities, and quantitative air features. Incident lung disease was determined by a study examiner. The relationship of the HOMA-IR to these outcomes was estimated in models adjusted for demographics, BMI, and lifetime smoking. A total of 870 participants with longitudinal insulin resistance data and outcomes were identified. Their mean age was 51.5 years old, and their BMI was 26.7. In adjusted models, a one standard deviation increase in HOMA-IR Z-score was associated with higher odds of quantitative emphysema, an odds ratio of 1.33, or a 33% increase over someone who did not have that, interstitial lung abnormalities, odds ratio 1.35, and modest increases in airway wall thickness and wall percentage. These radiographic findings were corroborated by positive association of HOMA-IR with incident lung disease. Neil?
John, I'll be brief here, but this was fascinating because we've known for a long time that people with diabetes have a higher incidence than people without diabetes of COPD. We also know that when you have COPD, there's a higher incidence of cardiovascular outcomes, cardiovascular mortality, than in people without COPD. And to think that insulin resistance, which is a core driver of diabetes and is a core driver of cardiovascular disease, also is a driver of lung disease, of emphysema and COPD, is nothing less than fascinating and just reflects the way every organ system in the body is interconnected, and how with our ever better scientific methods, we're learning that different organ systems don't exist in isolation. Treatment of one affects another, and all of it is interconnected. Our next article is from Diabetes Care, titled Life Course Associations Between Ambient Fine Particulate Matter and the Prevalence of Prediabetes and Diabetes, a Longitudinal Cohort Study in Taiwan and Hong Kong. And what the authors here looked at was fine particulate matter with a size, a diameter of less than 2.5 microns, exposure to people over time, and the development of prediabetes and diabetes. They looked at over 4,500 individuals, over 19,000 medical visits from 2 open cohorts in Taiwan and Hong Kong between 2000 and 2018, and they measured ambient particulate matter, essentially air pollution due to small particles. And that was assessed using a satellite-based model that looked at a 2-year average exposure over sizes, resolution of 1 kilometer squared. What they found was that an average follow-up period of 9 years, over 9.9 years, there were 1,660 individuals with prediabetes or diabetes. And for every 10 microns per meter increase in particulate matter, there was an increased odds of having prediabetes or diabetes, with an odds ratio of 1.3. The odds of adult Prediabetes or diabetes increased by 15, 18, and 29% for each 10 micron increase in particulate matter exposure during school age, adolescence, and adulthood, respectively. John?
So, Neil, I think this is a kind of a really interesting thing. So, when you think of these fine particles, they're 1/20th the size of the diameter of a shaft of a hair. So, teeny weeny things. These are things that, for the most part, are pollutants. These are things that come from the burning of fossil fuels. This comes from tobacco smoke. This comes from the industrialization of countries. And if you look in countries, probably this is going to be more concentrated for people who live in cities than people who live rurally. Oh, certainly you can have small particles from dust and from other things. But this is kind of part of which goes along with industrialization of countries. So if you look at where diabetes is developing around the world, really the country with the most people with diabetes right now is China. If you look at one of the other up and comers, it's India. So if you had to say, why is this happening in China and India? And I have postulated that it comes from the opening of fast food places in Shanghai and the introduction of sugared sodas and very much this Pima Indian type postulate that we take people and we expose them to high amounts of sugars and fats, and they can't just take it. And that might be a little bit, but the vast majority of the people living in a lot of these countries are still eating a traditional diet. And people eat a lot of rice, but people ate a lot of rice many years ago and really didn't have this incidence of diabetes. If you look at China and you look at average BMI, they're 149th in the world for average BMI. And you look in India, that doesn't necessarily have this high BMI. I think we're 10th in the world for BMI. So it really doesn't fit with that American model that we have fast food around the corner and we can eat it multiple times a day and we can drink 72-ounce sodas and things like this. But this one fits. So WashU did a study in 2019 that they did a similar study on these small particulate matter exposure and an increased rate of diabetes and prediabetes. Certainly, this is news to us, but not necessarily news to the scientific community. But this could explain things. And if you look at the industrialization of some of these countries, you look at still using coal, still having kind of levels of pollution in some of these countries that we don't have in the United States, this can lead to inhaling all these particles. So how does that make that leap to causing diabetes? Inhaling these small particulate matters gets into the lungs and could cause some inflammation. That inflammation can lead to some development of insulin resistance and then starting that cascade in order. Probably a different reason that we might be seeing diabetes developing in places in the world where there's not that model of people just getting heavier and becoming more likely to develop diabetes. It also, on the happier side, might be an easier way to change the course. If you could clean up some of these areas, if you could decrease some of these pollutants, like these small particles, that's the haze we see in some American cities that has a lot of pollution. If we could clean up the planet, maybe we can decrease some of this diabetes that seems to be spreading out to the four corners of the planet.
Our last article this month is a really important and interesting and practical article from the New England Journal of Medicine titled, once-weekly semaglutide in persons with obesity and knee osteoarthritis. Joining us to discuss this article is one of the authors, Dr. Sean Wharton. Dr. Wharton is the director of Wharton Medical Clinic, an adjunct professor at McMaster University, and is the lead author of the Canadian Obesity Guidelines, as well as an author on many of the major papers on obesity that form the evidence base for the medicines that we use for obesity, including the SURMOUNT-1 trial and the SURMOUNT-4 trial. Sean, welcome to our podcast.
Thank you very much. It's really nice to be here.
Sean, can you go over some of the background for this study, why you chose to look at osteoarthritis and semaglutide?
Great question. As we keep moving on in this field of weight management, so we're decreasing weight in a lot of these studies, but really what we want to see is the comorbidities getting better. So more and more, you're going to see is the add-on to, is the decrease in weight affecting the comorbidity? May that be fatty liver, may that be osteoarthritis, obstructive sleep apnea. So osteoarthritis was the one here. So that's what we're looking at, trying to see whether it's the decrease in weight will have a big impact on one of the most prevalent medical conditions on the planet, osteoarthritis.
Yeah, and it's so important. When I talk to a lot of people, actually when I talk to our residents, the thing they forget to pay attention to, everyone is aware of the cardiometabolic effects of obesity, but other than patients who have obesity, the rest of us sometimes forget about the biomechanical complications, and on a day-to-day living basis, these are critically important issues. Obviously, knee osteoarthritis for people with obesity. What was the methodology, briefly, for the study?
Yeah, and a lot of these methodologies are the exact same, which is nice and makes it easy. So what we're doing is we are randomizing patients with knee osteoarthritis. It was moderate knee osteoarthritis, so it was a KL score, that is a radiology score of the knee, and had to be either, so it goes from 1 to 4. 1 is not so severe, 4 is severe. We looked at patients with 2 or 3. So they had to have 2 or 3, BMI greater than 30, and they were randomized to either the medication or the placebo arm. And what we asked them to do was to stop their pain medications 24 hours before they came into the clinic, so we could assess their pain score based on not on a pain medication. We also asked them not to take any opioids. We tried not to have opioids in the study. A few ended up sneaking in, but that was the essence of the trial over a 1-year time frame.
That's great. So clearly a population that we see a lot of. And can you share with us the results?
Yeah, so the results of the study, what they looked at was a WOMAC pain score. So they looked at a pain score and they looked at the decrease in weight. Those were the two end points of the study. That makes sense. So let's just go with the weight first. The weight decrease was about a 13.7% decrease in the semaglutide arm, and the placebo arm was at a 3.2% decrease. So usually with semaglutide 2.4 milligrams, we're seeing anywhere from 13 to 15, 16% decrease in weight. So this landed right in that proper range. With the coronary artery disease patients, we see a lower amount of weight loss. We don't know why. Maybe metabolically there's something going on with coronary artery disease. We see about a 10% decrease in weight. But anyway, this was 13.7, pretty good. And then we looked at the pain score. The WOMAC pain score, it goes from 100 is a lot of pain to 0, which is no pain. These patients started at a pain score of about 71, so both in the placebo and the semaglutide arm. We want to see that decrease to a reasonable number. Decrease of about 35 points is a reasonable decrease, so you would like to see a little more than on that. And what we did see was in the semaglutide arm, there was about a 41.7 or so decrease in the WOMAC pain score, whereas in the placebo arm, it was 27.5. So there was about a 16-point difference there, and that was a pretty big difference that we don't normally see.
That's so helpful, and thanks for putting that WOMAC score in perspective. So it sounds like when you say that number of 35, that's considered the clinically meaningful improvement in pain?
Exactly. Clinically meaningful improvement in pain. Now, if you got a new knee, you'd hope that WOMAC score went from whatever it was all the way down to zero, as close to zero as you can. But if you're not getting a new knee, which has the complications associated with it, can you decrease that pain to reasonable numbers on the WOMAC pain score into the 20s as opposed to 70, where it actually is now? And the idea is without a ton of medication. Yeah, if you took a lot of opioids and you're passed out on your bed, you may not feel any pain. But that's not what we're looking for. We're looking for a decrease in medications and still have that pain come down to a reasonable number.
That's fascinating. And that decrease in pain, when we assessed that pain at the end of the study, that was off of all analgesics, right? They were not on Tylenol or NSAIDs or opioids.
Correct. They had to be off of that for 24 hours before coming in.
Yeah. So what do you see as the clinical implications of this study?
Yeah, and the clinical implications, it's important because sometimes when I think of the papers that I'm involved in, I think of why does a high-end journal take it? What made them take this paper? And whatever that is, sometimes maybe one of the most important clinical aspects of it. And I think it's because osteoarthritis is so common and pain medications cause a problem. NSAID pain medications cause ulcers. Opioids cause the opioid crisis. So if we can decrease the amount of pain medications that the world has to use for a common condition, knee osteoarthritis, that's a big deal. And I think and we saw a significant decrease in the amount of Tylenol used and the amount of NSAIDs used. And opioids were not supposed to be used in the program. It was stable because there was a couple people who snuck in with it. But if this was an opioid paper, maybe we would have seen a significant decrease in opioid use. So that's why I think it's important. Decrease in pain meds and an actual significant increase in the feeling of pain and the functional score. You could move better. You could get up from a sitting position better. A lot of things were a lot better.
Dr. Sean Morton, thank you so much for going over both the results and really what this means for our patients.
Terrific. Thank you.
For more information and links to the articles that we discussed in this issue, just go to diabetesjournal.org. Until next month, keep listening
And keep learning.